Dispensing controlled drugs requires balancing clinical care with strict legal compliance. You must ensure patients get the medication they need without crossing rigid legal boundaries. This chart breaks down the core classifications you will handle. Schedule 2 contains the most strictly regulated drugs, like morphine. Moving down the hierarchy, Schedule 3 offers moderate controls for drugs like temazepam, and Schedule 5 provides the least restrictive tier for medications like dihydrocodeine. Looking at the authorization requirements here, a valid script demands specific signatures. A junior doctor cannot authorize these alone. You must have the consultant's countersignature. Additionally, every script must carry the official hospital stamp. This map shows the geographical limits of a valid script. The prescriber's address must be within the United Kingdom. If the address is from Switzerland, an EU country, or anywhere outside the UK, the prescription is instantly invalid, regardless of the doctor's credentials. This slide details prescription expiration. Schedule 2 and 3 scripts expire exactly 28 days from the date they are written. That is a hard legal limit. If a patient brings you a 5-week-old prescription, you cannot dispense it under any circumstances. If any single element is missing, if a stamp is forgotten, a signature is unauthorized, or date passes 28 days, the prescription is legally dead. You must decline the fill. This list outlines the handwriting and form standards. For Schedule 2 drugs like oxycodone, the total quantity must be written in both words and figures. A plain clinic letterhead is not accepted. Private prescriptions must use a standardized form, like the FP10 PCD. This comparison shows where the rules slightly diverge. A typed quantity on a Schedule 2 script fails inspection. However, for a Schedule 3 drug like phenobarbital, a computer-generated quantity passes and is legally acceptable, provided all other patient details are present. This diagram outlines the collection protocols. When a family member or healthcare professional picks up a controlled drug instead of the patient, you are legally obligated to verify their identity and record their relationship to the patient in your controlled drug register. Lower schedules offer minor flexibilities in how a quantity is written, but verifying exactly who physically takes possession of the drug remains a non-negotiable legal requirement across all schedules. These guidelines dictate how to handle patients in distress. Visible withdrawal symptoms or a patient presenting empty medication boxes never override the law. In these situations, you refuse the dispense, explain the legal status, and refer them to the nearest healthcare facility. This case scenario illustrates a common pressure test. A patient who lives 5 hours away presents a perfectly valid prescription for 120 morphine tablets, a 60-day supply. To avoid the exhaustive travel, they ask you to dispense all 120 tablets today. You must split the dispense. You hand over exactly 60 tablets to cover 30 days. You then endorse the prescription with the quantity dispensed and the date, and you retain the paperwork for the remaining balance. This graphic emphasizes the hard cap. Even if a specialist writes a script for 60 or 90 days, the law allows you to release a maximum of only 30 days of supply at a single time. There are no shortcuts. You will encounter patients dealing with genuine hardship. Your role is to offer clinical guidance and empathy, but you channel that support into proper referrals, not into bypassing federal dispensing limits. This summary details the rules for an emergency supply. Without a prescription, you are permitted to dispense a maximum 5-day supply of Schedule 3 or 4 drugs. You can never use this exception to emergency supply Schedule 2 drugs like morphine. This graphic shows the protocol for a Schedule E life-threatening event. If a patient arrives in anaphylactic shock, you dispense hydrocortisone IV immediately. A missing requisition form is irrelevant when the patient will die without the medication. Once the crisis is handled, the paperwork follows. You update the Schedule E register with the batch number and quantity, and you secure the physician's retrospective signature within 24 hours. Standard pharmacy emergencies require strict 5-day limits, but when faced with an active life-and-death crisis, you intervene first and resolve the documentation second. This chart lists your internal documentation mandates. Your controlled drug register must be reconciled with a daily running balance. Every entry has to be written in ink, and a formalized independent audit must be completed every month. When Schedule 2 drugs like phenobarbital expire, they must be destroyed with an authorized witness and documented in the register. For Schedule 3 and 5 drugs, this witness requirement is removed, and standard disposal applies. This cheat sheet captures the exact parameters of your practice. 28 days for a prescription to stay valid, a strict 30-day cap per dispense, a 5-day limit for standard emergencies, and daily, ink-only audits. Operating within these exact numbers ensures your pharmacy remains compliant. By enforcing these rules consistently, you maintain the integrity of the medication supply chain and keep your patients safe.